0 to 18 or 21, to make sure that we are identifying early children with possible vision impairments and getting them to eye care. And that, of course, is the focus today. So we believe in equitable access to eye care. We are patient-led. We always want to be aware of what the patients are saying. We educate patients and families, of course. We do public awareness. And then we have training programs. We have a vision screening certification course. And then we also, I just want to mention, we have 6 affiliates. So if you in any of our affiliate states, I hope you'll reach out. Our headquarters is in Chicago, but we are national. We have affiliates in Iowa, Wisconsin, Ohio, Georgia, North Carolina, and Texas. So they cover, of course, their states, and then we cover the rest of the country. So we have been partnering with School-Based Health Alliance and also ACU, and our organization has been partnering with NAC for a few years now. And so I'll make sure to share all of our webinar and other resources. And then you can see here in the bottom right, we have several fact sheets, financial assistance, some vouchers for eye care, things like that, as well as we have information on every vision condition and why it's important to have vision screening. And then we have a whole toolkit for parent education for the younger grades, small steps for big vision. Thanks so much. Handing it over to you, Luke.
Hello and good afternoon. My name is Luke Hurdle. I'm the program director at the Association of Clinicians for the Underserved, or ACU. As Donna was saying a little bit earlier, we have been partnering with both School-Based Health Alliance, Prevent Blindness, and also the National Association of Community Health Centers to educate health centers on establishing and expanding vision services. So a little bit of background on ACU. ACU is a transdisciplinary membership network uniting clinicians, advocates, and organizations in the shared mission of improving health equity for the underserved. We provide professional education, training, technical assistance, and tools to clinicians and organizations around the country. We started working in the vision services space in 2017 by working with health centers to set up mobile vision screening events. But the need was so immense that from 2018 to 2023, we shifted to providing small grants to health centers to assist them with establishing or expanding permanent comprehensive eye clinics. Currently, we are offering training, or we offer training and technical assistance to health centers as well as workforce support. So you can see a number of different resources, a summary on the screen, and a QR code where you can get to our webpage to download these resources. So one of the key things on the top of the screen for what we do around technical assistance to health centers is we have a vision services committee, which is a 20+ person committee made up of optometrists, health center leaders, and advocates who provide guidance on ACU's vision services programming and training technical assistance to health centers as they start up or expand vision services. Our current co-chair of the committee also started the FQHC and Community Optometry Facebook group that brings together optometrists working in community health settings around the country to network, share best practices, or discuss shared problems. ACU also assists health centers with recruitment of eye care providers as we offer free job postings on our Career Center. And we also recently launched the 2024 Eye Care Workforce Survey, which aims to gain a better understanding of the current eye care workforce at health centers. As the number of optometrists and other vision services personnel has really exploded at FQHCs in the last decade. I also want to flag one last thing before I turn it over to our speakers, but a new resource which is available on our webpage that shares billing and coding tips as well as FAQs for vision services. With that, I'll go ahead and turn it over to Dr. Daca.
All right. Well, good afternoon, everyone. I'm very excited to get the opportunity to talk with you all. I have a unique perspective because I grew up in the FQHC world. My first job was in ophthalmology. Then I had the opportunity to be a staff optometrist with our FQHC, eventually becoming the chief and VP of the eye care department, and now serving as VP of medical affairs. So very happy and gracious to our leadership, our Rights, and our Chief Medical Officer, Dr. Monica Ryder, for allowing me to be able to participate and grow in our organization and be able to share some of that with you. Before I get started, I do want to also thank Donnie, Danielle, Donna, also Luke, the School-Based Health Alliance, and also the National Center for Children's Vision and Eye Health. So thank you guys. It's been an awesome an excellent process and easy, and we look forward to sharing. So, before I get started, I do have to say that I am not in my typical environment. MCR Health in Bradenton, Florida is actually dead center in the target for Hurricane Milton, which, you know, based on pressure readings and max wind speeds, probably one of the top 10 most strong storms of all time. So do keep our families, our properties about 10 miles away from the projected landfall at this moment. And also our patients and our staff, please keep them in your thoughts and prayers because they will need it, and it'll be a recovery and we'll be ready to go. But I am safely 2 hours away at a colleague's house. All right. So that being said, MCR Health, I talked a little bit about myself. I talked a little bit about our organization, and I talked a little bit about Bradenton. Donnie, next slide. So sharing a little bit more about our org, and this data is from 2022, which is what was reported. Unduplicated patients serve 168,000 patients and 812 patient encounters, right? When you're looking at our race, as reported, 50% is unreported, right? And 41% white, 9% African-American. Now, when you're breaking down by ethnicity, 24% are Hispanic. So that gives you a little bit of a picture of the patients that we serve, a mixture. Hispanic is a big part of our population in Bradenton. Next slide. One of the excellent things that I really enjoy about MCR Health is we're a diverse medical group. And I think it's important to share who MCR is because that kind of gives the picture of how we moved into school-based health, right? So it is directly related. But we are a large federally qualified health center, the second largest in the Southeast, the Southeastern United States. And you saw the patient numbers above. Family, internal medicine, peds, OB, and dental are our core services. A host of specialty services, because you know your family docs always want to be able to refer somewhere. So we've been able to branch and provide several services to our patients, as well as support systems, care coordination, health education, outreach team, financial counselor, pharmacy, and clinical pharmacy, right? That's not listed, but we do have clinical pharmacy teams that will do medication reconciliation, education with patients. So we are a full comprehensive healthcare system. We've been here since 1979, and we've been looking to slowly add services to offer to the community. Next slide. One of our core focuses is access for all, right? So that's one of our critical components. We are the safety net, right? And that's why we know that for federally qualified health centers and providing services to the community is so extremely important, right? Now, when you're looking at our mission statement, it's primary and preventative care, right? Including health, oral, behavioral, regardless of patients' ability to pay, and whether they have insurance or they're underinsured. So that's where MCR is. That's a paraphrase of our mission statement, and it's really about access to all. So when you're looking at that data from 2022, we provided $43 million in unreimbursed care. So that being a community health center, as you all know, is a challenge, and you're dealing with patients who may not have the resources. So working with the assistance grants, CMS, Medicaid, Medicare, that's really how you put together that program. Drilling down a little bit further, next slide, Donnie. Drilling down a little bit further, one of the big parts of our focus, our areas of focus, is our school-based initiatives. So that is something that has been evolving and launching over the last 5 years, right? And I'll first kind of go through the pictures. We're really excited. We have 3 real main school-based sites. The newest one is Daughtry Elementary, which you'll see in the top middle. You can kind of see the school principal and some of the administrators that helped to bring that into play. Now, if you're looking in the middle and the bottom, you're seeing portables, right? And they're true like portables, like if you were in a school and the school ran out of capacity and they added a portable, well, how can you add a portable and add some clinic space? Well, the Daughtry, the one that's in the tan, dead top middle, was a complete custom build, right? And it was built to withstand storms, which we shall see, right? And interesting enough, the one at Daughtry is actually a building that has two entrances. So if I can get you to look at the picture on the bottom left, you can actually see a gate, right? And you'll see a gate. There's an entrance from the community. So the community is a community health center nestled in with a Title I school. There's a community health center that you can go into that's accessible to the public. And the other half of the building is a school-based health center, which is actually accessible to the school. So the school nurse, the school teacher would walk the patients in, and the providers can see the patients on one side. And during the day, the providers can see the patients on the other side in the community. And the patients in the community cannot get into the school-based site without a badge access. So it's kind of exciting. The other clinics, actually, the Manatee Elementary, which you're seeing in the middle, a news ad from ABC7, MCR Health partners with Manatee School. There's a gate, but it's separate portables. There's a community portable, there's a school-based portable for pediatrics, and then a behavioral health portable in the back. But the Daughtry build-out was unique because it's connected. So that's talking a little bit about our school-based program at MCR Health. And I did skip one picture I want to go back to. In the center on the left, you see Dr. Price. You see the superintendent of schools, Wysong. On the right is our chief operating officer, Ms. Tabitha Ball. And on the far left is our chief medical officer, Dr. Monica Ryder. And lastly, you can't do this without community partnership, right? So the picture on the top right shares some of the partners that helped to launch the program, of especially the Daughtry Elementary School, USF, Centara, Community Health Systems, the Manatee County School District, Boys and Girls Club. So it was really a full throttle communication with our leadership team and the various groups to get the funding and the resources and the planning to really get that done. All right, Donnie, next slide. Perfect. Now, coordinating development, deployment. How do we get out and take our vision services to those school-based systems? Well, it really boils down to consents, right? That is the biggest challenge, is getting enough consented patients. You can have everything in place, but if you don't have the consents, you can't provide the service. As you all know, in the healthcare clinics, when the patient walks in the door, they're going to consent to their care. A child is unable to consent. So when that child needs care or you're looking to schedule, if the parents don't sign the homework or they're non-responsive, you're missing that opportunity. So that is one of the biggest areas where we really should be focused on, is consents, right? Now, how have we become more successful over years getting more consents? Let's do it during open house. Let's partner, let's go to the open house and get them to sign up at the beginning of the school year, right? Also, let's make it a competition between classrooms, because this is really a benefit where the kids can get care without the parent having to take off of work or the kids having to miss school. So how can we really make this a priority for the school by speaking to how it benefits the child and also the school being able to provide care or provide education without those kids being out? Now, staff and providers should support those school events when they have sign up, when they have Halloween events, when they have events in January going back. We should really take a time to send one of our bubbly staff members for that 6 to 8 sessions to interact with the parents, and the word of mouth in the community will take off. And bring the consents with you, but better yet, have everybody sign in at registration, which really requires the buy-in of district leadership as well as school leadership. Now, this is a lot of work, right? Meeting the school system, having those communications, those conversations, making those agreements, getting the contracts in place. But once that patient is in your healthcare system, they're a lifelong patient, right? You have their information. Even if they don't come back for 4 or 5 years, you were able to evaluate them. And a lot of these patients, even though I've been at FQHC for almost 10 years, we schools and we see people that have never been there, right? Also, the parent and family get exposure to your organization. when you send in the medical records to the parent, you may be acquiring another patient, right? So there is a residual benefit and exposure. As those school buses add throughout the day, as your units are there, and as you saw on the prior slides, if you make it a feature, it becomes in the news and it really can become a good thing for the health center. Next slide, Donnie. And I'll keep it efficient because I have about 3 minutes left. Coordinating deployment. Communication is key. Health centers and schools have vastly different cultures, right? Our community health center has a lot of military influence, and once command has a report out, the communication structure is very different. I found with the schools, you really have to determine the level of the administrator. Are they reporting to the district, or are they reporting to that individual school? Are they responsive, or are they not? So make sure you identify who you're speaking to and check in regularly, right? I'm going to have a deployment in December. I expect to have a full book of patients in November. Our team will be verifying insurance the first 3 weeks prior to the event. If there's any changes, 1 week prior, we'll communicate. And if we do need to pull out and reopen a provider schedule, 7 days out is the last minute timeframe. So have that buffer and have that clear communication. Next slide. Now, we want to provide clear vision care, right? Now, one of the things I did want to touch on, what are we seeing? I spoke on, we're seeing patients that maybe never got to the eye doctor, right? One of the things with these school-based deployments in kids, it really does tend to lean more towards routine vision. We don't gear up for full medical, treatment. If we diagnose something, we will say, hey, we want to follow you in a clinic so we can do a full workup. So we're really looking on those undiagnosed headaches, eye strain, binocular vision issues, amblyopia, lazy eye, how comfort they are with reading, managing the double vision. And you're dealing with a patient population. We have elementary schools. They may not be responsive. So you're really gathering the information and providing it to the parent, the school resource, and the patient so they can be successful. And in high school, they're much more responsive. And when you get to the high school, you're starting to look at glaucoma and patients that maybe wouldn't have made it to the doctor for social economical reasons. And you're able to kind of put them on a path where they don't have to face blindness. Next slide. So to kind of wrap it up, we want to be very clear. And this is my lovely wife, Emily. She's also an employee at our community health center, and my beautiful babies. But we want to prepare in advance regarding eligibility. Make sure you have a central contact. And if you're deploying glasses, plan to get back in 2 to 3 weeks after to dispense the glasses, get those dates lined out in advance. Next slide. I'll touch on this quickly. These are patients that don't have the ability to get to the doctor, right? Community health centers prioritize health education, getting patients on the patient portal. We're not here to really take from the patients. We're really here to provide. It's better for us to do this than for an outside source to do it, because we're going to do it with the patient first in mind. Consents, communication, and really focus on the clear vision. We can provide excellent care. Next slide. And once again, just a big thank you to everybody. Again, keep our area in your thoughts, and it was great to be able to share a little bit about what we do.
Thank you so much. We'll turn it over to Clifton. And while we're waiting for those slides to come up, if you have not already dropped your questions into the chat, please do so. Had some great questions come in during Dr. Daka's presentation, so keep those questions and comments coming in. We appreciate you sharing your strategies. So we will turn it over to Clifton to get started. Thank you.
All right, good afternoon, everyone. Danielle, you can see my slides, I'm good?
I can.
Okay, great. Well, good afternoon, everyone. As they have said before, I'm Clifton Bush. I'm the Chief Operating Officer for a federally qualified health center in Southwest Georgia called Albany Area Primary Healthcare. So again, I'm going to be talking about our school-based vision clinics today, and giving you some resources and tools that you can use, you know, for your future vision center, or if you already currently have a vision center.
And Clifton, I think we lost your presentation for just a second there. So while we're waiting for that to come up, I'm just looking at the chat. And thank you for those comments. Jose said, great presentation to Dr. Daka. Are there, just scrolling to see if there were any other questions or comments, lots of well wishes for Dr. Daka in the Central Florida community. So thank you for that as well. But we also had a great comment as far as consent. Some great strategies being used as far as how to increase consents. Going home in the school packet, in the parent packet or guardian packet at the start of the school year. That's a great one.
Clifton, would it be helpful if I pulled up your slides?
Yes. Yes, go ahead and you can control it. Thank you.
Awesome. So I'll turn it back over to you, Clifton, to get started.
All right, so information about Albany Area Primary Healthcare. We were established in 1978, and we're currently, institution was incorporated in 1979. So we've been in existence for over 40 years. The organization we actually developed through a grant for some funding in a county called Lee County, based on a thesis project regarding the lack of prenatal care for women and babies in the community. And so 30 years later, we actually do and have implemented OBGYN care. In 1982, we had 3 locations. As of today, we have 30, and it includes 11 school-based health centers, and 3 of them have vision services. We started our first school-based health center in March of 2013 at an elementary school that's K-5. Next slide. So a little bit about our optometry department, and then I'll get into our school-based health center optometry department. We currently have 1 optometrist on staff, currently just hired an ophthalmologist. So we have an ophthalmologist on staff and have another interview with another optometrist on next week. So hopefully we'll have some additional optometry providers on staff eventually. At our school-based health center, the staffing includes an optometrist. We also have an optician that's at the school-based health center, along with 2 optometric technicians. Sometimes we use 1 technician, and sometimes 2, just depending on how many students we have coming in for the day at the school-based health center. According to our UDS, in 2023, we served 3,681 patients within our optometry department, and then we served 4,506 patients in our school-based health center patient encounters since the opening of the school-based health center vision clinic back in 2018. We also serve patients at 2 of our outpatient clinics, community clinics, with over 21,000 encounters to date for this optometry program. And I'll talk a little bit about the community clinic as well. Currently, we have 3 optometry sites, along with our optometry on our mobile unit that we utilize within the school-based health center program. Next slide. So how did we start this vision program within our school-based health centers? We received some funding in 2017 from the One Site Foundation to start a vision center. And this funding included construction of the site, salaries for 1 year for an optometrist, optician, and an optometric technician, and a front desk receptionist. So what we decided to do, and wrote it in for front desk person, but we decided to get 2 optometric technicians, and instead of a front desk person, kind of optometric technicians. They actually check the insurance the day before, check the insurance for the students as they come in, if we have any walk-ins, and they do like the clerical work as well. With this program, we also were able to offer free frames for patients that met the poverty guidelines. and did not have vision benefits for their frames. So we was able through the One Sight Foundation to do that, and it also allowed us to open a community clinic. So just operationally, we was trying to decide, kids get out of school in the counties we serve at like 2:30, 3:15. So kind of what to do with the staff for the rest of the time, for the rest of the day. So what we decided is to do the school-based health center operations in the morning, and then in the afternoon, the optometrists will work in one of our community clinics, right down from one of the main school-based health center sites. And so that has worked out very well, where we can kind of serve the community, and kids will have somewhere to go when school is out during the summer, but we also serve the kids within the school system. We also received some funding from the Association of Underserved Clinicians to start another vision center at one of our school-based health center sites. So we got some funding for some equipment to start at Dooley County Elementary and Middle, which was one of our other vision sites within our school-based health center program. Next slide. So our space and clinic, this is actually one of our school-based health center clinics, actually the first one that had vision services. You can kind of see the frame areas, and also one of the exam rooms. But we used a classroom that was located within the elementary school for the vision center. And right across the hall in this same vision center, we have medical services as well. So that medical team can do, again, that integration of care. They can refer patients over same day if we're there, et cetera. So we have 2 exam rooms, 2 lanes. We have a pre-test room, a front desk receptionist area. We have a workstation area for the optometrists and the optometric technicians, a workspace area for the optician, a space for the frames, which is where the optician sits. And then we have a small waiting area for the students and the patients, any patients that come in, because sometimes we do see faculty and staff and their siblings as well within our clinic. And so so again, this is a classroom, and we took it and changed it into a optometry clinic. Next slide. So services that we offer are, vision exams for the students, siblings of the students, the faculty and staff, and we also serve the families of the faculty and staff, their siblings as well. We also have frames on site. One of the interesting things that we try to do is try to encourage the parents to let the patients, the students pick out their own frames instead of the parent picking out the frames, because what we found is that if the students pick out their own frames, that they're more likely to wear the frames than the parent picking something out for them and they don't like the frames. So we do try to encourage the parents to allow the child, if they need glasses, notify the parents and allow them to pick out the frames that they like within the center. Again, ophthalmology services is now something that we're able to offer, and transportation services via the school system. So we was able to, with the main school system where we have about 13,000 students, to have the school buses transport kids to the vision center. So again, we're in one elementary school in a county called Dougherty County that has, again, about close to 13,000 students within the school system. So the superintendent, we had conversations with him, and we transport kids over on a daily basis to the vision center, the school buses. And so how it works is we normally have a school set aside per day, or 2 schools, depending on the number of kids that we have coming from the school, and if the schools are near each other. And we transport those kids over on a daily basis. We always try to keep the elementary kids, together, and middle. We don't put elementary kids with high school kids, but we'll, transport elementary, by themselves. And sometimes if they're, 8th graders, they can come with the high school kids. So again, that has been a tremendous and great service, because now it allows all, almost 13,000 students within that school system have access to this vision clinic. And I'll talk about, again, a little bit more about the process in just a minute. Next slide. So our optometry clinic process is that we have consent forms. We send consent forms home to the parents every year for them to complete during the first week of school. We also utilize other types of methods. We're at open house, giving out consent forms. We're at PTO meetings. We're at utilizing the parent facilitators within the school system. We also have a patient navigator within our school-based health center department. It helps with all these consent forms, any type of health fairs. We're always, looking at different types of ways to make sure consent forms are visible and we're giving those out. But mainly we give them out every year at the start of school, and we have a pretty good return rate. We do some contests at times to get the consent forms back, just like a classroom that brings back the homeroom class that brings back the most consent forms will get a fruit and yogurt party. We did that one time, or they will get a gift card to certain places, et cetera. So we've done different things, that type of consent form contest to get forms back into ASWORK. And then we have our patient navigator and our optometric technicians that work the consent forms to get students scheduled that haven't been to a optometrist or haven't seen optometrists, or they may be having issues with their eyes. Also internally, our pediatricians, our family medicine providers, and our school-based health center primary care providers refer patients also to our school-based health center vision clinic. So, if they have a child and they know by asking the parent, because one of the questions when they're doing their notes is what school does the child go to? And if they go to a particular school where we have a vision center, then they more than likely will refer them to the vision center within the school. So the parent, take off work, they can utilize the transportation system that we have. We also get referrals from AAP, providers, again, within our network, and those are optometric technicians. And we also have a dedicated referral specialist as well for our school-based health program. Again, I talked about the transportation. It's provided for the students to the services in all of the school systems that we serve. We also have mobile unit services. So at one of the school systems, we actually take the mobile unit to the school system and utilize our mobile unit for those vision services twice a month. Next slide. So operations and sustainability. We do build in students insurance. Most of the students, majority of the students that we see have Medicaid. And so we do build in insurance to keep, the clinic sustaining, which, also includes frames if they need frames. If a student does not have insurance or the parent cannot pay for the vision services, we do not turn any student away. We still see them. We actually, for frames, have a foundation set up within our organization where employees like myself, I pay into the foundation each pay period. And employees can wear like jeans every Friday if they do that. And so anyways, we utilize foundation dollars at times if a student does not have insurance and the parent don't have money to pay for the frames, so that they can make sure that they can, be able to see, so they can do well in school. We also make sure to schedule the patient back for the annual exam. So the optometric technicians oversee that and make sure the students get back in for the annual exams on on annual basis. We also have access to the school system's Infinite Campus website. And Infinite Campus is basically where we can locate what school the child is in. If they move to another school from the previous year, it will show us what school they're currently at. We also have access to the student's phone number, the parent's name, et cetera, the emergency contact, so we can reach them. So that has been a great benefit for us, especially because we're serving multiple schools, and we can, if a child moves from one school to the next, year after year. We've also set up 1 or 2 schools daily, again, to be transported to the school-based health vision center for services. So we have a great process where the students are transported. When they leave the school, there's a checkoff list that we send the day before, letting the front desk office manager know who is to get on the bus. And when they get to us, we have the same checklist. We check actually the bus driver brings it, and they check off who got off the bus. And when they get back on and get back to the school, that same checklist is making sure all the students are accounted for that have been transported to make sure that everybody's getting where they need to go safely.
And Clifton, there were a couple questions that came in before you wrap, just about how the transportation is funded and what type of consents are required around that. And
Yes.
then a question regarding if a student is screened that does not have insurance.
Say that last part again about insurance, sorry.
What happens if the student was screened and does not have insurance?
So that I'll answer that one first. If a student is screened and don't have insurance, we'll still see them. Like I said, we don't turn away any student that does not have insurance, or we find out that insurance is inactive, we still see them. And again, our techs do check the insurance the day before. So normally that doesn't happen, but again, if it does and something slips through the cracks, we still will see them. Because we want every child to have, access. As far as the transportation, in our consent forms, we have where parents can opt. If they sign a consent form, they can opt in or opt out of transportation. And so that's also in like our MOU with the school system as well, that students will be transported. But again, in the consent form, the parents can opt in for transportation. And so if they sign it stating that they would like to be transported, that's how, we can transport their child to the Vision Center. And what was it was one more question, Danielle, sorry.
One more question came in about, will you bill the parents?
So yeah, if a child again doesn't have insurance, normally what we do is we just write that off. Again, we don't deny a child for, normally it's just written off, but again, majority of the kids that we serve have insurance, or if their insurance has fallen off, we do have social workers and within our organization that can help the parent help them complete the Medicaid application to get them back enrolled. And a lot of times Medicaid will retro back 6 months. So we do have those things in place as well, where our social workers, we have a social worker dedicated, again, towards school-based health somebody that can help with that.
Awesome. Thank you, Clifton. And there were some more questions that came in the chat for you, but we'll transition to Tiffany. But if you can respond to those folks directly in the chat, more questions are coming in for you as well. So I will turn it over to Tiffany. Oh, Tiffany, you're on mute, I think. I think you're talking to us.
I am. So once I start
Okay.
sharing, it stops letting me. So give me 1 second. I'm gonna share my
Okay, perfect.
screen. I think, is that better?
Perfect. Yes, thank you.
All right. Good afternoon. I'm Tiffany Wace. I am the Chief School Health Officer for Health Partners of Western Ohio. Very honored to be here. Vision Outreach Services is a newer service for us. So we, like the other two presenters, are a federally qualified health center. We are as our title, as our name suggests, we are in the western part of the state. A little history about us. We have 22 health centers. 13 of them are full comprehensive school-based health centers. So 13 of the 22 are school-based health centers that operate Monday through Friday, 7:30 to 4. And then we also have dental and vision outreach services. So I'll go over our vision outreach services today and how we've made those happen. All right, let me see if it's going to let me advance my slides. Okay, so a little bit about our the state of Ohio. So in the state of Ohio, vision screenings for school-age children are required preschool, kindergarten, 1st, 3rd, 5th, 7th, 9th, or 11th grade. And so unfortunately, the students who fail their vision screenings, the majority of the students do not actually get a comprehensive eye exam. 80% of kids who fail those vision screenings that are done by the school nurse at the school that are required do not actually receive comprehensive eye exams. And so that is very disheartening. And I will say that actually in the last State of the State address from our governor, he did address the concerns regarding vision and kids getting access to vision services, specifically because it so largely impacts academic performance. And so in 2022, and I'll give a little bit of history later, but in 2022, we started our vision outreach program. And it is a mobile service that we have vans. So we have mobile vans that go out. So this is a fleet of our mobile and dental vans on all of those vans there. And so the one is that you can see is our vision van. We do have 6 vision teams currently, but this is our vision van. And we used to, before we had the vans, because it takes a little while to get them built, we did actually have portable equipment that we went in the school and set up services right inside of the school. That is a little bit harder and a little bit more cumbersome. It's much easier when you have the van because everything is right there and set up. But it is possible to be able to do that if necessary, especially during startup timeframe. And so the vision vans are very helpful. They have come in handy a lot with our teams, especially when we need to do follow-up visits with our students and go back to the schools. So a little bit about our process. That's what I'm going to largely focus on today, is just kind of our process. So we do have a rotating schedule. So we go to schools throughout the school year. So our staff start up in August and go all the way through the end of May, and they are in a different school every week. And so we send flyers home to our families, letting them know. The school districts also use social media, school newsletters. There are also like platforms that the schools use, like Class Dojo or Remind, that they send home information to families to let them know that we will be in their school. We do collect all consents, and I'll go over consents in a minute, but we do collect all consents at the beginning of the school year. So we do have this flyer that goes home, just letting people know when exactly we're going to visit their school for vision services. So we have a consent. Our consent is both for dental and vision. People can opt into one or the other or both services. We do find that this is very helpful for us to be able to just have it on one consent, because it's the school nurses doing a lot of the collection of the consents. So the less that they have to collect, the better, because it is a lot of work on their end. So we do have the ability to do electronic consents, but we have received from our families that a lot of them, it is really beneficial for them to have it in their hand at the beginning of the school year, that it goes home to them. If you miss the beginning of the school year, it's really super hard to collect those consents throughout the school year, just because people are out of the mindset of back to school timeframe. The challenge that we have on our end actually is the volume of consents that we receive. So due to staffing challenges, Ohio has a shortage of optometrists and opticians. We are actually only able to see about 50% of the kids who we get consents back for. So we do have to prioritize kids for services, specifically because we do receive so many consents back. So this consent goes at the beginning of the year, and then the flyer goes later, just as a reminder, hey, you signed this consent and we will be in your kid's school at this set time. So the outreach process, the school nurse is the person who we usually connect with, or they have a designee, secretary, assistant principal, things like that. So we coordinate with the school nurse. We register all of the patients before we go to the school. And then, as I mentioned, that we can only see about 50% of the kids who we have consents for. We do prioritize kids who have failed vision screenings, who need it. In the state of Ohio, it is required by law that kids who are being assessed for an individual education plan have an eye exam, or kids that staff or parents are concerned about. So we do prioritize those students. And we complete a priority list before we go to school, and then we start younger grades up if we have more time outside of that priority list. And then we also coordinate our consents according to classrooms, because Miss Smith's classroom doesn't want to be disrupted 14 times throughout the day sporadically. So we really do try to just disrupt Miss Smith's class to see all of her kids back to back. and then we move on to the next classroom. So the classroom teachers really appreciate that. So they know that maybe for the next couple hours, their classroom is going to be disrupted, but it isn't going to be all day or all week that their classroom will be disrupted. So this is the inside of our Vision vans. Everything is secure, so it doesn't roll around and when we are transporting or moving between place to place. So this is the inside. We take our van, like I said, we're at the school for a week, seeing as many students as we are able to. And the students who need glasses, we do glasses frame selection right there at the school. We can do it inside of the van if necessary, but some of the schools do have a little bit of space right inside of the school that they let us use to help with frame selection. So we do have a licensed optician who goes and helps support frame selection. We send home with each student a letter to their parents and letting them know what has happened. And it is actually a triplicate document. So we have a copy, the school has a copy, so the school nurse keeps a copy. Because sometimes parents, instead of calling us, even though that's what we've asked them to do, they will call the school and ask questions. So the school nurse has the information, and then then the parent has it as well. So it is a triplicate that goes home, and everybody really appreciates being able to have that. We will refer students out to ophthalmology if necessary, or circle back to students, like I said, who maybe need additional follow-up. Maybe their prescription was too strong to be able to jump right to that prescription for the first pair of glasses. So we will circle back to those students as well. So these are some of our beautiful faces that are getting glasses. My staff say glasses dispensing day is their favorite day of the week, to be able to go out and dispense glasses. So the opticians will dispense glasses. We go and deliver them back to the school within 2 weeks. The optician is the one who does that. And then they also will, like I said, conduct referrals as necessary. The other thing that's really important is making sure that we replace broken or lost glasses. We did have a school nurse who was wanting to hold on to glasses because she wanted to make sure kids had them in school, and although her sentiment was good intention, it's really important that kids have the glasses that they need all of the time, not just at school. So we really had to support the understanding that we will cover lost or broken glasses. So we do bill insurance if they have insurance. There is no out-of-pocket cost for the program. That does include glasses. So we, as a federally qualified health center, are committed to seeing people regardless of their ability to pay. And when we did start up our program, we have had some operational funds. It has not covered all of the program, but we have had some operational funds that have helped us offset the cost from the Ohio Department of Health. That has helped us launch some of our vision services over the last couple of years. So in 2022-23, we had one vision team. We were at 32 schools. You can see the numbers there of the number of students. And I know that the number of kids who got glasses seems high, but as I said, those are the students that we do prioritize. It has been a challenge to grow the program due to staffing challenges, and it is especially difficult in rural and underserved areas, such as our urban areas, or right directly in the city. Last school year, we grew from 1 to 3 teams, and we had 2.75 FTE of an optometrist and 4 for optician. The optometrist does have a day where they are just catching up on notes and doing in-office work, so the optician can go out and dispense glasses. And then you can see our numbers there. So we were 102 schools with 6,000 unduplicated students. This school year, we've expanded to 6 teams. You can see we are, the counties that we serve are located. So the yellow stars are where we have a school, or where we have a health center, and our school-based work in our vision outreach surrounds those. So we added this year optometric technicians to be able to provide some help as well, and receptionists. They enter all of the consents in to make sure that we are ready and prepared for the school so that the team can have the best time possible. And then a coordinator as well, because it is a lot of communication with the school nurses and the school staff. So this year we anticipate 150 schools. And our dental outreach program is actually in 500 schools. So we really do want to grow to be able to provide services to all of those schools as well. So if you have any questions, feel free. This is my contact information. And thank you for allowing me to share, hopefully some operational nuggets with you guys to be able to move your work forward.
Thank you so much, Tiffany. And thank you to all of our presenters, Clifton, Dr. Daka. This was wonderful, and we've had so much engagement in the chat. So to the attendees, thank you for joining. Thank you for being engaged. If we have not made it to your question, Donnie, if you can put back up how to reach out to us and stay connected for folks just to document that information. And if we didn't get to your question today, please follow up with us, email us. We want to make sure that we connect you and get you the answers that you need. Donnie has also just launched a poll. We really want to hear from you about today's webinar session. It helps us continuously improve and just really get you the content that is most useful for you and those that you serve. So please just take a moment to do that evaluation and let us know how we did today. And I want to make sure I'm just scrolling through the chat. Again, if your question wasn't answered, if we didn't get to you today, please make sure that you reach out to us. We just so appreciate you joining today. And thank you.
And with the follow-up, we will include our information again so we can make those connections with all of you so we can get your questions answered. We can make that reach out to each of the presenters and say, hey, we still had some lingering questions. So that will be included with the follow-up along with the slides, the recording, and some other resources.
Perfect. Thank you, Donnie. All right. Thank you. Thank you, everyone. I appreciate that. Yes, keep all of our Florida folks in mind. Thank you. Thanks, Kim. All right. We just have a minute or two left. And Tiffany, I know there were a lot of questions that rolled in as you were going through your presentation. One came in about the cost of like the outfit of the van, I believe. And I'm not sure if you can really give specifics. I'm sure it really depends. But maybe if you can speak to that. But I think Suzanne had a question, how much does it cost to fully equip a vision specific van?
So I would say that our vans that we have are about 250,000 per vehicle.
Thank you. Thank you for that.
And it depends on exactly what you're looking for. So it can, be more or less, really kind of depends on what you're looking for.
So let's see if there was like at least one more we can get to. Oh, there was one question about follow-up. Can you talk about how the vans go back for follow-up, if you can quickly touch on that one?
Yeah, so we have one day a week that the optician may be dispensing, that we have somebody else go out with the optometrist, like a tech, go out with the optometrist, and they may visit multiple schools in a day. So they may have 5 at one school, 3 at another school. So they're moving from school to school on those days. So it is a little bit slower day. But they will circle back to those schools specifically to see those targeted students who need more follow-up.
Awesome.
And the vans allow that, where our portable equipment does not, because you have to tear down everything and then set everything back up.
All right.
Hey, Danielle, can I jump in on that too?
Absolutely.
Briefly. So you're going to be limited with, as an optometrist, you'll be limited on what services you can offer. There's OCT, there's funded photos. So really prepping a team that could support them. So as a health center, maybe a referral team that could get them to office-based staff, or maybe saying, hey, 10% of these or 5% of these are actually going to have medical conditions. Let me have somebody that can follow to make sure that that gets done as appropriate. So, this is, you're screening and you're looking to take care of the routine vision needs. But if you find an urgent issue, you do need to make sure you have a network to support those patients.
Great.
We work very closely with medical and ophthalmology as well. Yeah.
That's a great point. Thank you. I know we're just over time. I Appreciate all of our partners and presenters joining us today, and as well as our attendees. And thank you again for being so engaged. Please stay connected with us. Thank you so much for being here. Have a wonderful day. Take care.